In this lecture, we are going to introduce the structures of the respiratory system. As mammals, we have a small surface area to volume ratio and lots of cells. We also have a high metabolic rate because we move, we need to maintain our body temperature, so we need a lot of oxygen into our cells and we produce a lot of carbon dioxide as waste. And in order to cope with this high load and need for oxygen, then we have organs that work together as a system to do this gas exchange, and we have this as the respiratory system. So these are all the organs of the respiratory system, and we're going to talk about them in turn. And what we're going to be doing is all these systems are working together for gas exchange. We want oxygen into the cells and we want carbon dioxide out of cells. And the only place where this is actually going to occur, this gas exchange, are in the alveoli. And we'll talk about gas exchange on its own in a separate lecture. Everything before the lungs is called the upper respiratory system. And you might hear you might have had an upper respiratory system infection. So that means you've got an infection before the lungs, and the lungs are the lower respiratory system. And we'll talk about the structure and function of each of these systems in turn. To work our way through the structures of the respiratory system, we're going to start with where the air enters the respiratory system, and we're going to start with the nose and the nasal cavity. Now, in the nose and the nasal cavity, we're going to warm the air, filter the air, and moisten the air. Now, the way the air is warmed, in the nose we've got a large surface area and a very good blood supply, and this starts to warm the air to body temperature, and this is better because it helps to make gas exchange more efficient. And if you think about how cold the air can be and how our body's at 37 degrees Celsius, it's good to start warming this air so that you don't have this big temperature difference when the air gets inside the body. We filter using hair and mucus. So we've all got hair up our nose, so we've got this hairy lining, and that secretes the mucus. Mucus is sticky and will trap dust and bacteria, and it helps protect from irritants and infections getting into the lungs, because any of these materials will get trapped in the sticky mucus and will either be blown out into a tissue and disposed of, or will be swallowed, dripped down to the back of the throat, swallowed into the stomach and destroyed by the stomach acid. The air is also moistened, so we're going to increase the humidity of the incoming air, and this will help reduce evaporation across the exchange surface in the alveoli. So it means that the air that you breathe in into the alveoli will have a very similar humidity to the moist surfaces inside the alveoli. If we breathe through our mouth, which we can do, the warming and the moistening is not as efficient, and we haven't got that filtration system through the nose hair and the mucus. So it's best to breathe through your nose and your nasal cavity when you can. And you actually cycle through which nostril that you breathe through. So you'll breathe through one nostril and then you'll switch to the other nostril. And your body does this without you even realizing you're doing it, which is absolutely fascinating, I think. And it means this system together means that the air we breathe in, once it gets to the alveoli for gas exchange, is a similar temperature and humidity to the lungs and to the humidity levels in the alveoli themselves. The air will now pass through the pharynx and then through the larynx. So the pharynx is the back of the throat, and this is where both air and food can travel. And we've got this epiglottis that will cover the trachea when we swallow food, to make sure that food goes down the esophagus rather than into the trachea, which would be very bad for infections. You don't want to get food in your lung, for example. We'll talk more about swallowing when we talk about the digestive system. The larynx is transports the air from the pharynx to the trachea. It's where we make sound. I will put some links to a video about looking at the pharynx and the larynx internally with cameras. We'll have a look at that and how you can generate sounds in your larynx in some links that I'll provide for you. The trachea connects the larynx and will split down and start to move the air down into the lung structures. It's got lots of cartilage, so it doesn't collapse. We don't want the trachea to collapse. We need to keep our air pipe, our windpipe open at all times for gas exchange. Very flexible, so you can twist and bend your head. And it's because you have these what we call rings of cartilage. So if this is a trachea, you've got these C-shaped rings very close together, but not totally connected. So you've got flexibility to bend the trachea, so you can bend your neck and also twist as well. The cartilage are C-shaped rings. So they look like this, the cartilage, and you've got an area where you don't have cartilage, and this is where the esophagus runs, the pipe that takes the food from your mouth down into your stomach, the tube that does this. And this means that when you swallow food, the food can bulge out into the trachea without impeding the flow of the food. So you've got these C-shaped rings, so you're still supporting your trachea, but you can still swallow food and get it down into your stomach. The lining of the trachea the epidermal lining produces lots of mucus and is ciliated. So ciliated means it's got little tiny hairs. And these have cells within the ciliated epithelium that produce a nice layer of mucus. This image is taken by a light microscope, and we've made a thin section has been made through a section of trachea and stained so that we can see the colour. This is inside here, this is inside the trachea, so this is the lumen of the trachea, the whole of the trachea, and you've got this epithelial layer here, and hopefully you can see the little, it looks almost fuzzy. This is the little hairs, the cilia here as well, and these cilia will move and waft and they sweep. They have like synchronized movements, and we have goblet cells that will secrete mucus. So here is a goblet cell here, like this, and there's one over, you've got one here as well. These goblet cells secrete a nice layer, I should make it green, a nice layer of mucus across the surface of the trachea, and then the cilia will sweep the mucus. Now the mucus is really sticky and will trap dust, dirt, bacteria that you inhale will get stuck into this mucus. Remember, you've also got the filtering of the mucus in the nose. This is another layer of filtering as well. And then the cilia will beat and sweep the mucus and anything that's stuck in it up, 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 away from the lungs, up to the throat, and then this mucus with all the dirt and the microorganisms will be swallowed and into the stomach and digested by the stomach acid. So this is working all the time to keep your lungs clear. So hopefully anything that gets past the nose will be trapped in this mucus and swept up in the trachea. If you smoke, one of the things that's happening is that the cilia stop sweeping, they stop beating, and they become paralyzed. I'll put a link, there's a link to a video showing the synchronized beating, sweeping of these cilia in the topic book that's on the Sway, and I'll make sure that you have a clear link to that video. This image is taken by a scanning electron microscope, and this is looking across the surface of the trachea. It has much higher resolution, and what you've got here, it's a beautiful image, but all these little lines that you can see, these are the cilia. So these are the things that will beat and sweep, and you can see it looks like the hairs on a sweeping brush. And this big structure here, this is a goblet cell. So this is the cell that will secrete the mucus that helps to stick the dirt and the bacteria to. It's a beautiful image. The trachea then divides into the bronchi and then the bronchioles. and you've got two bronchi. You've got one going to the left side to the left lung, and another going to the right side of the lung. Bronchi is the plural for two of them. Singular is bronchus. And if someone has bronchitis, that means they've got inflammation in their bronchi. The bronchioles have just got a smaller diameter. So the bronchi divide to lots of little bronchioles. Very similar structure, but narrower. Once you get to the very small bronchioles, the very small versions, as they get smaller and smaller, so the bronchioles with a diameter of less than 1 millimeter no longer have cartilage. But the rest of the bronchi and the bronchioles do have this cartilage to keep the airway open at all times. They have a smooth muscle lining, and that can control the size of the passageway when it contracts. So if people are having an asthma attack, one of the things that happens in an asthma attack is the smooth muscle in the bronchi and the bronchioles contracts, and that makes the airway smaller. So it's harder to get air into the lungs for gas exchange. You also have a buildup in mucus, not the good stuff, mucus that is kind of uncontrolled. So when people have their inhalers that they take, one of the things they can do is they have a muscle relaxant to relax or relax the smooth muscle so that the bronchi and the bronchioles dilate and are larger so you can get more air into the lungs. We are then down to the lung structure itself. Now, lungs are elastic, soft. They feel really spongy if you ever get a chance to feel a lung, and they can collapse altogether. It's this idea of them being spongy. They float on water. They're lots of air sacs in them. Left side is on the right when you look at it. Right side is on the left when you look at it, and this is because it's left of the patient rather than left to you as the person viewing the patient. Left side of the heart has two lobes sections, and again, when I show you a dissection, if you get to see a dissection yourself, you can feel these lobes. They're kind of separable, almost flaps of lung. So you've got the lobes shown here. So this is one lobe and two lobes here. So two lobes on the left. On the right, we have three lobes. So you've got a lobe here, a lobe here, and a lobe here. Left lung has two lobes and is slightly smaller because this is where the heart is. Now, obviously, that's not the shape of the heart. You know that, but it's easier to draw it that way. So left side has the heart, so slightly smaller lung structure on the left-hand side. For some illnesses, surgeons can remove parts or even entire lungs, and the patient will be absolutely fine. So if a person has lung cancer in one area, you could remove an entire lobe and that person would be okay. If it's more severe, you can remove a second lobe, and again, the patient will be okay. You can even remove an entire lung, and the patient, again, as long as they have normal breathing function before the surgery, they will have normal breathing function after the surgery. The other lung can compensate, which is kind of incredible when you think about it. The lungs themselves feel spongy and soft and elastic because they've got lots of air pockets. They're made up of structures called alveoli. The singular is alveolus. And these alveoli are little air spaces, and this is where gas exchange takes place. And we'll talk more about the structure and the function of the alveoli when we talk about gas exchange. But they have a very extensive blood supply so that they can bring the deoxygenated blood and take away the oxygenated blood, and a very large surface area to make this as an efficient process as possible. The lungs themselves are not physically attached to the ribs or the muscles surrounding the lungs. They are attached through surface tension. And what we have surrounding the lungs, we have two pleural membranes. So we have, this is one membrane here, and this is the second membrane here. So you've got these two pleural membranes surrounding the lung and lining the thoracic cavity, and inside this space, in the pleural cavity, you release a pleural fluid. And this pleural fluid reduces friction so that when the lungs are expanding and when we inhale and deflating when we exhale, we're reducing friction, so we're not going to damage the lungs. And it also means that this fluid attaches the lungs to the inside of the rings using this surface tension. So it means that if you pull on one membrane when the ribs are moved up and out when you inhale, then you, through surface tension, you pull on the other membrane, and then this pulls on the lung as well. So that's the pleural membranes. People can get infections in the pleural membranes. So people who have, you might have heard of the infection pleurisy. This is where a patient has an infection in the pleural membranes, and this surface tension is impeded and very painful. The lungs and the heart as well, that's in there as well, are protected by bones called the ribs. And between the ribs you have these intercostal muscles as well that are there to change the shape and the volume of the rib cage when we're breathing. So they've got an important role in breathing, and also the ribs are there for protection as well. So you've got these rib structures here like this. In terms of the muscles we have external intercostal muscles and internal intercostal muscles. The external intercostal muscles, when they contract, they raise the ribs. So the ribs go up and out, and this is important in inspiration when we're breathing in. And these external intercostal muscles account for 25% of the force that's needed when we inspire. And we'll talk about that more when we talk about the mechanisms of breathing. Internal intercostal muscles, when they contract, they are going to work to lower the ribs, and they are involved in some forms of expiration, breathing out. So not passive expiration when we're just sitting and breathing quietly, but when we are running or we force the air out of our lungs, forced expiration, that's when these internal intercostal muscles will work. But like I said, we'll talk about that more when we talk about the mechanisms of breathing. The final part of the respiratory system to talk about is the diaphragm. So the diaphragm is shown in the bottom here. This is the broad dome-shaped muscle, and it separates the thoracic cavity from the abdominal cavity. And it is involved in most of inspiration. So when we are breathing out, the diaphragm is relaxed into a kind of a dome-shaped structure. When we inspire or we breathe in air, the diaphragm contracts, becomes less dome-like, and this accounts for 75% of the air that we inspire is pulled in by this contraction and flattening of the diaphragm. And we'll talk about more about how this occurs when we talk about the mechanism of breathing in our next lecture. Thank you.